The wheezing started in the waiting room. Not the mild breathlessness I'd experienced before during bad allergy seasons, but something deeper, tighter, like breathing through a straw that kept getting narrower. "You're fine," my sister Lauren said without looking up from her phone. "Stop making that noise." I tried to speak but couldn't get enough air to form words. My chest felt compressed. Each inhale a struggle that yielded almost nothing. I stood up, thinking movement might help, and immediately felt dizzy. A nurse at the triage desk noticed me swaying. "Are you all right?" I shook my head, pointing at my chest. She was already moving toward me when Lauren intercepted her. "She's fine, she does this." Lauren's voice carried that particular mix of exasperation and amusement she reserved for my dramatics. "She has anxiety, gets herself worked up and then hyperventilates. It's literally all in her head. Ma'am, she looks cyanotic." The nurse was staring at my lips, which I couldn't see but could feel were numb and tingling. "She always looks pale. She's being dramatic. Trust me, I'm her sister. I've seen this a million times." The nurse hesitated, looking between us. In that moment of hesitation, my legs gave out. I didn't pass out, not completely. I was aware of hitting the floor, aware of the ceiling tiles above me, aware that I couldn't breathe at all now. Couldn't pull in even the inadequate sips of air I'd been managing. Everything happened very fast after that and simultaneously too slow. Voices shouting, hands on me, an oxygen mask that didn't seem to help. Lauren's voice, distant, still insisting I was fine, just having a panic attack. "Oxygen saturation is 79%. Get respiratory in here now." Anaphylaxis. Did she eat something? I heard all of it through a growing fog. The lack of oxygen was making everything soft around the edges, dreamy and terrifying at once. I was 20 years old, in a hospital emergency room, and I was drowning in air. They intubated me. I learned that later in the ICU, when I woke up with a tube down my throat and a ventilator breathing for me. Severe asthma exacerbation triggered by environmental allergens, complicated by delayed treatment. My lungs had essentially stopped functioning. Another 5 minutes and my brain would have been oxygen deprived beyond recovery. Lauren visited once during my 6-day ICU stay. She seemed annoyed that I couldn't talk around the breathing tube. "Everyone's asking about you. What do I tell them?" I wrote on a notepad the nurse had given me. "Almost died. Don't be dramatic. You're fine now." She checked her phone. "I have to go. I'll tell everyone you're recovering from a bad asthma attack." She never acknowledged her role in the delay, never mentioned how she'd convinced the triage nurse I was faking. When I was finally extubated and could speak, I tried to bring it up. "You told them I was seeking attention. I almost died." How was I supposed to know it was serious? "You've always been overdramatic about every little thing." The pulmonologist who managed my care, Dr. Martinez, was the first person who really listened. She sat beside my bed and explained everything. The pathophysiology of severe asthma, the cascade of events when airways constrict, the critical importance of early intervention. "Minutes matter," she said. "Every minute of delayed treatment increases the risk exponentially." My sister told the nurse I was faking. Dr. Martinez's expression hardened slightly. I read the intake notes. The delay was documented. "You're lucky you collapsed when you did, or you might not have been taken seriously until it was too late." Something shifted in me during that conversation, a clarity I hadn't possessed before. I was pre-med, had been planning to go to medical school, but without real conviction. Now I had purpose. I wanted to be the doctor who believed patients, who didn't dismiss respiratory distress as anxiety, who understood that sometimes the difference between life and death is whether someone takes you seriously. I wanted to be Dr. Martinez. Medical school was brutal, but I'd experienced something more brutal. Every anatomy exam, every biochemistry problem set, every clinical rotation was easier than not being able to breathe while someone laughed at you. I told my story once during a small group discussion in our clinical skills course. We were learning about patient communication, about how to build trust and rapport. When the instructor asked about experiences that shaped our approach to medicine, I talked about the emergency room, about the nurse who hesitated because my sister was convincing, about the minutes that passed while I suffocated. The room went quiet. My classmates looked uncomfortable, but the instructor, a seasoned emergency physician, nodded slowly. "That's why we have protocols," he said. "That's why we don't let family members override clinical judgment, but it still happens, too often. I specialized in internal medicine first. 3 years of residency where I learned to manage everything from diabetes to heart failure. But I was always drawn to the pulmonary cases, the patients struggling to breathe, the ones who came in with oxygen saturations in the 80s, eyes wide with fear. I understood their fear in ways my colleagues couldn't. When I held their hand and said I was going to help them breathe easier, they believed me, because I'd been there. I'd been the one who couldn't breathe. I applied for pulmonology fellowships in my final year of residency. 3 more years of specialized training in lung disease, respiratory failure, and critical care. My personal statement was honest. I'd nearly died from delayed treatment of respiratory failure. I wanted to ensure no one else did. 12 years after my sister convinced an emergency room nurse I was seeking attention, I became an attending pulmonologist at the same hospital system where I'd almost died. I was good at my job, maybe because I'd been on the other side. I knew what it felt like to gasp for air while someone dismissed your panic. I knew the terror of lungs that wouldn't work. I never, ever assumed a patient was exaggerating respiratory distress. My colleagues joked that I had a sixth sense for bad outcomes, that I could look at a patient and know they were crashing before the monitors showed it. It wasn't a sixth sense. It was memory. I'd been the patient everyone assumed was fine until I wasn't. Lauren and I hadn't spoken in years, not since I'd stopped returning her calls in medical school. Stopped attending family events where she'd tell the story of my dramatic hospital stay like it was comedy material. Our parents had tried to mediate, but I'd been clear. I had nothing to say to someone who thought my near death was funny. The patient assignment came through on a Tuesday night. I was on call, reviewing admissions from the emergency department. Respiratory failure, severe pneumonia, oxygen saturation in the low 80s. 42-year-old female, history of smoking, presenting with progressive dyspnea. The name didn't register at first. Lauren Morrison. It's a common enough name. Then I saw the emergency contact, our parents' number, the same one I'd blocked years ago. I pulled up the full chart. The patient photo confirmed it. My sister, looking terrified in a hospital gown, oxygen mask over her face. The attending from the ER had noted, patient requires ICU-level care. Consulted pulmonology for management. Appears to have severe community-acquired pneumonia with impending respiratory failure. I stood in the hallway outside the ICU for a full minute before going in. Professional distance, I reminded myself. This was a patient who happened to be related to me. A patient who'd once prevented me from receiving timely care for the exact type of crisis she was now experiencing. My hands were steady as I reviewed her chart one more time on the hallway computer. Vital signs unstable. Chest X-ray showing bilateral pneumonia. Blood gases showing inadequate oxygenation. This wasn't a mild case. She was genuinely sick, the way I'd been genuinely sick 12 years ago. Part of me wanted to feel satisfaction. The poetic justice of the moment wasn't lost on me, but mostly I felt the weight of responsibility. Because regardless of our history, she was my patient now. And I'd taken an oath. Her room was third on the left. Through the window, I could see her in the bed, oxygen mask on, monitors beeping steadily. She looked small, frightened, diminished by hospital equipment and illness. Exactly how I must have looked 12 years ago. I knocked and entered. She turned her head toward the door. And I watched recognition dawn in her eyes. First confusion, then shock, then something that might have been fear or shame or both. Maya? Her voice was muffled by the oxygen mask, weak from the effort of breathing. Dr. Santos, I corrected, pulling up her chart on the room computer. I'm the pulmonologist assigned to your case. You're a doctor? I've been an attending physician here for 3 years, specialized in pulmonary critical care. I was reading her vitals, her lab results, her imaging. The pneumonia was extensive, bilateral infiltrates, inflammatory markers through the roof. She was sick, genuinely, seriously sick. Your oxygen saturation is 84% on 6 liters. That's concerning. I can't breathe. She said it the way I remembered saying it, the desperate confession that something is very wrong. I know. That's respiratory failure. Your lungs aren't exchanging oxygen efficiently because of the infection and inflammation. I made notes in her chart, ordered additional treatments, adjusted her oxygen delivery. We're going to increase your respiratory support, start you on aggressive antibiotic therapy, and monitor you closely. If your oxygen requirements increase, we may need to consider intubation. I watched fear flash across her face at that word, intubation, the breathing tube, the ventilator. Will I die? She whispered. Not if I can help it. Your condition is serious but treatable. I see much worse outcomes in patients with better initial presentations. I pulled up her chest imaging on the monitor. This is your chest x-ray. See these white areas? That's consolidation, fluid and inflammation where air should be. We need to clear that infection and reduce the inflammation so your lungs can function properly. Maya, I'm scared. Dr. Santos, I said again. In this hospital, I'm Dr. Santos. She closed her eyes. When she opened them, they were wet. I'm sorry for what I said. Back then, when you told the emergency staff I was seeking attention while I was in respiratory failure, I didn't know. You didn't want to know. There's a difference. I finished my documentation. Your nurse will be in shortly with medication adjustments. I'll round on you again in 6 hours. If your breathing worsens at all, tell the nursing staff immediately. They'll page me. You're really going to be my doctor? I'm the pulmonologist on call, and you need a pulmonologist. Unless you prefer to wait for someone else to be available. I let that hang in the air. We both knew she couldn't afford to wait. I'm very good at my job, Lauren. I became very good at my job specifically because of what happened to me. Because I know what it's like when people don't take your breathing seriously. She looked at me for a long moment. I really am sorry. That's between you and your conscience. Right now, my concern is your pulmonary function. I headed for the door, then paused. For what it's worth, I don't let personal history affect my medical judgment. You'll get the same standard of care I give every patient, which is excellent care because I take respiratory emergencies very seriously. Someone should have taken mine seriously. Over the next 4 days, I managed Lauren's care with meticulous attention, adjusted her antibiotics based on culture results, titrated her oxygen to maintain adequate saturation, consulted with infectious disease when her fever persisted, ordered appropriate imaging to track her progress. She improved slowly. The oxygen requirements decreased. The inflammatory markers trended down. By day 5, she was transferred out of the ICU to the regular medical floor. I saw her once more before discharge, doing final rounds. You saved my life, she said. I did my job. That's what doctors do. We don't ask if patients deserve saving, we just save them. I didn't let them save you. No, you didn't. And I remember that every single day when I walk into this hospital, I remember what it feels like to not be believed. So I believe my patients. I take respiratory complaints seriously. I don't assume anyone is being dramatic when they say they can't breathe. I told everyone you were exaggerating. For years, I told that story like it was funny. I know, I heard about it. I didn't understand what I'd done. Not until now. Not until I couldn't breathe and thought I was going to die. I closed her chart. You're being discharged today. Follow up with your primary care physician in 1 week. If you experience any worsening of symptoms, increased shortness of breath, fever, chest pain, go to the emergency room immediately. Don't wait. Don't assume it's nothing. Respiratory issues can deteriorate quickly. Will I see you again for follow-up? You'll follow up with the outpatient pulmonology clinic. I work primarily in the hospital setting with acute cases. She nodded slowly. Thank you for taking care of me, even though I didn't deserve it. Everyone deserves medical care, Lauren. That's the point. That's what you didn't understand 12 years ago. Whether you think someone is being dramatic or not, whether you believe their symptoms are real or not, they deserve to be evaluated by medical professionals, not dismissed by family members who think they know better. I left her room and continued my rounds. Saw 5 more patients that shift. Each one got my full attention, my complete focus, my serious consideration of their symptoms. Because I knew what it was like to not be taken seriously, knew what it felt like to drown in air while someone laughed, knew the terror of your body failing while people assured you that you were fine. Lauren was discharged that afternoon. I never saw her again. I heard through hospital staff that she'd followed up appropriately, that her pneumonia had resolved, that she'd quit smoking after the scare. I don't know if she changed. Don't know if almost dying gave her the perspective that almost killing me hadn't. Don't particularly care, if I'm honest. What I care about is that I'm the doctor I needed 12 years ago, the one who believes patients, who treats respiratory distress as the emergency it is, who doesn't dismiss gasping and cyanosis as attention-seeking. I'm the doctor who takes breathing seriously. Because I remember what happens when nobody else does. My sister learned that lesson in my ICU, under my care, breathing oxygen I prescribed and taking medications I ordered. She learned it while depending on my expertise, my training, my commitment to saving lives regardless of personal history. She learned what I already knew. that breathing is never dramatic when you can't do it, and that the person you dismiss today might be the specialist you need tomorrow. I became a pulmonologist because my sister convinced medical staff I was seeking attention during respiratory failure. 12 years later, she was alive because I didn't return the favor.